Okay, good morning and good evening, all my friends of the ICC webinar. I am Dr. P.Y. Cho and my co-moderator, Dr. Junior Tu and Dr. Pryor will co-moderate this session. Today, we are so happy to invite a very important teacher, Professor Johnny Liaw, and the three very well-known panelists to come join this panel discussion. First of all, I would like to invite Prior to give me the warmest introduction for all our guests and the presenter. Please, Prior, thank you.
Hi everyone, my name is Per. Today I will be the co-moderator for the ICC webinar. And I'm so happy that today we have a participant from many countries to join this session. Hello friends and colleagues in Taiwan, Vietnam, Malaysia, Philippines, Cambodia, Thailand, and Azerbaijan, India, Pakistan, and also Australia as well. Welcome everyone to join. For the ICC webinar, we open for everyone to learn together in every session. So we always welcome everyone to join. And today we have a distinguished attendant from Taiwan to give us the presentation. And before we go to the session, I would like to introduce our three panelists today. The first one is Dr. Yifang Liaw. She is the Dean of the Craniofacial Orthodontics from Shanghai Memorial Hospital. The second panelist, Dr. Trang Ho. She is the chair of the orthodontic department from Universities of Medicine and Pharmacy at Ho Chi Minh City, and also the president of Ho Chi Minh City Association of Attendants. And the third panelist, Dr. Rangrat Kamonthip. She is the president of the Thai Associations of Attendants. And thank you very much to our three panelists that giving your time to join us today. And now it's time that I would like to introduce Professor Johnny Liaw to everyone. Professor Johnny Liaw, he's the president of the Taiwan Association of Attendants in 2013-2014, and he's also the chair of Taiwan Board of Attendants in 2015 to 2016. And now he is the clinical instructor at Orthodontic Department, National Taiwan University Hospital from Taiwan. Actually, I would like to say that I call Professor Johnny Liaw as my senior because we graduated from the same program.
Sure. My pleasure.
And now it's time that for the Professor Liaw presentation, Professor Johnny Liaw will give the presentation in the topics of Orthodontic Excellence Achieved with TADs and Interdisciplinary Treatment. Welcome, Professor Johnny Liaw.
Okay, thank you so much for the kind introduction. I'm much honored to be here as a part of ICC webinar. So let me start my presentation. First of all, greetings from Taiwan, and the topic I'm going to share is Orthodontic Excellence Achieved with Interdisciplinary Treatment with mini implant, dental implant, and auto transplant. In addition to part-time teaching at the National Taiwan University, I work in a private practice, and totally we have 9 orthodontists and 4 general practitioners and 2 prosthodontists and also 2 periodontists. Together with the dental assistant, we work together as a team, and together everyone achieves more. Let me start with the first case. Here we have a protrusive lady, and we may see from panoramic X-ray the upper left lateral incisor was missing, and there was a cantilever bridge over the 2 central incisor and the missing lateral. and 2 low molars were ill-fitted crowns, and there was also 1 hopeless upper right first molar. Her chief complaint was severe protrusion, but in consider her situation, we decided to extract 4 premolars to reduce the protrusion. But as for the extra molar, first molar space at the upper right, we decided to try to close the space. So we started with the provisional crowns, and after that, we hand on aesthetic pontic of the upper left lateral incisor for the aesthetics. And we got 4 premolar space here, and also 1 extra molar space at the upper right. As I have said, in consideration of her protrusiveness, we tried to maximize the retraction, so we decided to close the extramolar space. But when we tried to close the extramolar space, the dental midline tend to shift to the right. So we have to use the IZC mini screw on the upper left to control the dental midline. So when we close most of the spaces, we can see the dental midline were coincident. And the dental midline was kept very well when we closed most of the spaces. However, here is the problem. She was still so protrusive. But there was not enough overjet. So I decided to put a 2 buccal shelf test to retract the lower dentition so that we can keep retracting the upper dentition. So with these 4 mini screws at the posterior, we can retract both arches. At this time, the anterior tests are also very important, because when we try to retract more, the anterior teeth will tend to dump. There would be a bowing effect. So we need anterior tests for incisor intrusion for the vertical control. After a large amount of incisor intrusion and retraction, we can see the crown of the central incisors became very short. And there were some exoastosis over the labial bone. So we need to send the patient to the periodontist for crown lengthening to restore the appropriate crown length and also reduce the exoastosis. And here is the final outcome we can achieve. In terms of occlusion, it looks pretty nice. And the facial profile, although the facial profile was not very ideal, but it make a significant improvement. Here is the OPG before and after. We close all the spaces except the upper left lateral incisor, which was restored by an implant prosthesis. And here is the cephalometric superposition. We can see there, in addition to a large amount of incisor intrusion and retraction, we also achieve some counterclockwise rotation of the mandible so that we can improve the facial profile. And what is even better, during our follow-up, we can see there seems a little bit neuromuscular adaptation after we correct the hard tissue. The soft tissue adapt after we correct the hard tissue. And the chin projection looks much better than pre-treatment. So I think this case is a very good example of interdisciplinary treatment. With the collaboration among prosthodontist, periodontist, orthodontist, we were able to provide the best possible treatment outcome for our patient. what we treat is the patient's malocclusion, but what we change is the patient's life. And this is the beauty of interdisciplinary treatment, isn't it? If you are interested in more details of this case, please refer to this paper in AJODO Clinical Companion. And for an adolescent patient with protrusion and badly decayed molars, we may prefer to extracting the teeth of poor prognosis, upper left first molar and lower right first molar, to balance, to reduce the protrusion and also to balance the extraction spaces. We decided to extract the upper right and lower left second premolars. But we plan an auto transplant from the lower left second premolar to the lower right first molar space and close all the spaces. But with this extraction pattern and the auto transplantation, we can reduce the space discrepancy in the lower arch to avoid the midline deviation during space closure and eliminate the need of the dental implant at this young age. So after full strap up, we started to close the spaces over the lower right molar, first molar, until there was a premolar size. Then it's time for the auto transplantation from the lower left second premolar to the lower right first molar. After transplantation, bite razors were added. Bite razors were added to avoid the occlusal trauma. The space closure was proceeded to correct the dental midline. You may notice here the dental midline were off and the interdigitation was not good. But after we close all the spaces with the control of the mini screw on the upper, we can make the upper dental midline coincident and improve the interdigitation. So here is the treatment outcome. The profile improved pretty much. Ideal overjet and overbite, bilateral canine class 1 relationships. There is only one thing that you may notice here at the lower right quadrant. We have 3 premolars. We have 3 premolars, but the interdigitation looks pretty good. Here is the OPG before and after. And the cephalometric superposition looks pretty good. Profile improvement, maximal incisor intrusion and retraction. So in addition to orthodontic space closure, auto transplants could be another viable treatment option for missing teeth, especially in adolescent patients with at this young age, to avoid a dental implant at this young age. Without auto transplantation, we may need a dental implant at the lower right, in which the patient was too young to receive a dental implant. If we try to wait, it would be challenging. It would be challenging to maintain the space and also difficult to maintain the alveolar ridge. If we decided to close all the spaces, we may need a test for lower right protraction, which was more difficult and unpredictable. The lower dental midline may shift to the right. It was my pleasure to present in 2015 AAO in San Francisco entitled "With Tough Case Made Easy with TADs and Interdisciplinary Treatment." I share this case of 4 mouth rehabilitation with 2 auto transplants and 1 dental implant. Here you can see 2 auto transplant and 1 dental implant here. Periapical film of these 2 transplants looked pretty fine. With the help of TADs, we can maximize the retraction to reduce protrusion, intrude the upper incisors to correct the gummy smile, and move the occlusal plane upward so that we can get counterclockwise rotation of the mandible to improve the chin projection. The mandibular angle was reduced from 45 degrees to 41. I got some feedbacks as good job, but I got even more question about the stability. So let's see how she looked like 5 years later. Here is 5 years follow-up records. The occlusion looks fine. The lady looked even younger than pre-treatment 10 years ago. How about the auto transplants? The periapical film of these transplants look pretty good condition on both auto transplants. Well, it seems to be an acceptable treatment modality. So what are the keys to the treatment success for this mutilated dentition with multiple missing? To me, I will say TADs, dental implant, auto transplant, and interdisciplinary treatment are all very important keys. The last but not the least is the passion for the orthodontic profession. And that's why we are here today. I'd like to go through these 3 keys to elucidate how we can treat this mutilated dentition. As dental implant could not be moved after installation, so when the dental implant come across orthodontic treatment, the questions are where and when. So how can we decide the implant position? Dr. Smalley suggested to duplicate a set of models with index and make the model setup, then use the silicone index to transfer the ideal implant position back to the original model so that we can fabricate the surgical guide to install the implants and provisional matrix to make the provisional crowns. However, when we see some case report following this protocol, we may find the interdiscitation are not so good. The prediction is not always very reliable. So I like to share my rationale of implant also combined treatment with this case. Here we have a severe protrusion case with multiple missing. You may see the lower first molars, bilateral lower first molars were missing, and there was one lower right first premolar also missing. To reduce her protrusion, we decided to remove 2 upper first premolars, and we tried to use the mini screw as anchorage because there were not enough posterior teeth as anchorage. After we upright all the teeth and manage the space, then 1 dental implant on each lower quadrant will be installed to restore the missing tooth. For maximal retraction, we use the IZC test to provide the distal force. As the line of action was very low below the center of resistance of the upper incisors, so there would be a tendency to dump the anteriors and detorque the upper incisors. So we use the upper anterior test to apply the intrusive force to counteract the anterior dumping and provide the palatal root torque. In addition, a torquing spring was also used to apply the palatal root torque. To level the curvus B in the lower arch, a lower anterior test was used to intrude the lower incisors. To upright the low molars, a segment of open coil spring was inserted in front of the molars. The distal force above the center of resistance of the low molar tend to tip back the low molars. The reciprocal force tend to flare the lower incisors. So we use a low posterior buccal shaft test to retract the lower dentition and avoid the lower incisors from flaring out. At the same time, the lower dental midline was off to the right. So I asked the patient to wear asymmetrical interarch elastics for midline correction. After clear access of the implant insertion has been achieved, I think it's time to install the dental implants. So I talked to the implantologist to install the dental implant 1 millimeter off to the regular position, 1 millimeter distal on the lower right, 1 millimeter mesial, 1 millimeter distal at lower left, and 1 millimeter mesial at the lower right to help the dental midline correction. Here is the panel right after implant installation according to our plan. After a couple of months for osseointegration, provisional implant prostheses were fabricated. I was then advised by the prosthodontist to intrude the upper incisors, to intrude the upper first molars to get more appropriate space for implant prosthesis. For dental midline correction, a segment of open coil spring was inserted in front of lower right first molar, the provisional implant prosthesis, to correct the lower dental midline to the left. 5 months later, we can see the dental midline were coincident, and the interdigitation on the right buccal segment improved pretty much. Here is the treatment comparison. The occlusion looks pretty good, and the facial profile was reduced significantly. The OPG before and after. And this is an example using dental implant as anchorage to fine-tune the final occlusion. And here is the cephalogram. The superimposition showed a great amount of upper incisor retraction. After debonding, alveoloplasty was performed to remove the exoastosis and crown lengthening to restore appropriate crown length, so that we can finish the permanent prosthesis like this. For the implant also combined cases, my first concern is the space management. To achieve the clear access for implant installation, and moved all the present teeth to confirm the ideal implant position. You may find tests would be very helpful to design appropriate force system and provide reliable anchorage. The implants should be installed as soon as the clear access of implant insertion was obtained, and the ideal implant position were confirmed. We may indicate the implant position by how much space to close or how much space to open between the implant prosthesis and the adjacent teeth. After osteointegration, the provisional implant prosthesis should be made as soon as possible so that we may know what further orthodontic tooth movement we need to proceed. We may also take advantage of the absolute anchorage of dental implant to finalize the occlusion. Over years, implants has been a gold standard to restore the missing teeth, and TADs are applied in implant also combined cases successfully to improve the final results. So we have discussed about where and when to install the dental implants. The next question is how. I'm not going to talk about how to install the dental implants. The patients are more interested in how many implants they need and how much it will cost them. So psychologically and financially, autotransplantation provides an opportunity to recycle the natural teeth and save the money. This lady complained of protrusion. She got 2 upper left premolars missing. To reduce the protrusion, the treatment plan was 1 premolar extraction in each quadrant, except the upper left, where no premolar could be extracted anymore. With 1 premolar space closure in each quadrant, there will be 1 space left at the upper left, which needs a dental implant to restore. If we can include autotransplant in our treatment plan, we may treat this case without a dental implant. So after initial strap up, the upper left, the lower left second premolar was extracted first because the periapical lesion may compromise the prognosis of autotransplantation. The other 2 possible candidates of donor teeth were bonded to make them loosen for atraumatic extraction. Autotransplantation was done in the 2nd month from lower right second premolar to upper left second premolar. The reason of this choice was lower left second premolar was single-rooted, which made the prognosis better. And the number of roots is very easy to identify from CBCT images. You may also use 3D printout replica to preserve the PDL cells of the autotransplant during the procedure of trial fitting. Then the autotransplant was stabilized with bracket and a soft LH archwire. According to this article published by Tokyo Medical Dental University, it was recommended to use the improved super elastic tie-9 archwire, which was also known as LH archwire by commercial name. LH archwire is named after low hysteresis, which is characteristic of vibrational force absorption. This will greatly reduce the occlusal force transmission. It may reduce the risk of ankylosis by applying more physiological force after autotransplantation. And it was concluded that early application of orthodontic force may improve the success rate of the autotransplant. So after transplantation, root canal treatment should be done within 2 weeks to avoid external root resorption caused by endotoxin released from the necrotic pulp. As for the timing to start the tooth movement, a histological study done by Tokyo Dental College suggested 2 months interval for the periodontal reattachment. But in this case, actually, I started the space closure 17 days after autotransplantation. Some colleagues asked me, how dare you to rush? The reason is that I use the test as anchorage in the posterior teeth. And I use the LH archwire to listen the force transmission for the anterior retraction. So the force are focused on the anterior teeth and tests. Nothing to do with the auto transplant itself. You may see the space closure was smooth and all the spaces were closed smoothly. And here is the treatment comparison. The occlusion looks pretty good and the facial profile was well reduced. One auto transplant successfully replaced one dental implant. Superposition showed a very typical correction of bimacular protrusion. Here is OPG before and after. The periapical film showed very good condition of roots, PDL, and the bone. Here is 8 years follow-up, still very fine. And the occlusion very stable as usual. I learned the auto transplantation procedure from this book written by Dr. Tsukiboshi from Japan. But I modified the procedure to stabilize the auto transplant with bracket and a soft LH archwire. As an orthodontist, I prefer to use archwire to stabilize the auto transplants. In comparison with the dental implants, auto transplant is a kind of biological replacement with normal PDL. So it is possible to move the auto transplant with orthodontic force, and it may erupt with adjacent teeth. With PDL, auto transplant is possible to create alveolar bone and tend to have normal gingival papilla. In this case report from Poland, even there was no labial plate. At the time of auto transplantation, with PDL, new bone was formed at the labial of the auto transplant. So if there is any opportunity for auto transplantation, I would be more than happy to try it. We have gone through dental implant and auto transplant. The next would be TADs, which is very important for profile retraction, gummy smile correction, and improvement on chin projection. I'd like to recommend a combined intrusion and retraction force system supported with TADs, which I proposed in AAO meeting in 2018 in Washington, D.C. on adult gummy smile correction. This lady was definitely a surgical case for severe protrusion and the gummy smile and with so retrusive a chin. But she did not want to go for orthodontic surgery with the understanding that the treatment result might be compromised. We decided to remove 4 bicuspid and the wisdom teeth, then use combined intrusion and retraction force system on both arches, trying to intrude and retract the dentition. However, here we can see anterior open bite. The intrusion in the front teeth seems to be okay. However, the intrusion on the posterior teeth are not as successful. But at this time, I decided to install one more mini screw distal to the terminal molar on the buccal side and another mini screw on the palatal side to focus on molar protrusion, on molar intrusion to close the anterior open bite. 4 months later, the open bite was gradually closed. And we may settle the occlusion like this. there were intraoral conditions at debonding. After massive amount of retraction, the alveolar bone looked like exoastosis. So a periodontal surgery, including alveoloplasty and crown lengthening, was performed to remove the exoastosis and restore the appropriate crown length. And this is post-periodontal surgery. And here is the comparison. Extraoral comparison showed the correction of the gummy smile and improvement on the facial profile and chin projection. Cephalometric superposition showed intrusion everywhere so that we can reduce the total facial height and rotate the mandible counterclockwise to improve the chin projection. The mandibular angle was reduced from 45 degrees to 41. The combined intrusion and retraction force system on both arches, with the emphasis on molar intrusion, occlusal plane could be moved upwards. So this is how active vertical control after extraction, maximal intrusion and retraction with the active vertical control, then counterclockwise rotation of mandible to reduce the lower anterior facial height to improve the chin projection. How is the stability? This is how she looked like after 3 years and 9 months follow-up. The overall superposition showed reasonable stability. To see it more clearly, superposition were made pair by pair. There might be some relapse on intrusion, but overall changes are still very cost-effective. Before, after, and follow-up. Even there might be a bit of relapse, the changes will be subclinical. Now we are ready to treat this case together. This lady complained of protrusion and multiple missing. She got the gummy smile and also asymmetrical condylar size and shape. So skeletal asymmetry, canted occlusal plane, gummy smile, and severe skeletal discrepancy make this lady a surgical case. The ideal treatment plan was proposed to remove the wisdom teeth and replace the missing molars with dental implant. Then 1 premolar extraction at each quadrant except the lower left. Then close all the premolar spaces, and OGS was indicated to correct the skeletal discrepancy, including protrusion skeletal discrepancy. However, this lady declined the surgical approach and asked for minimizing the number of dental implants. Finally, we settled the treatment plan as upper right first premolar extraction plus 2 wisdom teeth removal. Then close 1 space in each quadrant. 2 auto transplants were planned to reduce the number of dental implants. So only 1 dental implant was left at the lower left first premolar, which saved a lot of money for this lady. Now this lady was happy with the treatment plan. So let's go through the treatment progress briefly. After initial strap-up, upper posterior TADs were installed for maximal retraction. Anterior TADs were inserted for bi-opening and gummy smile correction. In conjunction with the molar intrusion force on the upper right, it will help to correct the occlusal plane cant. At the 9 months, first auto transplant was done from upper right second premolar to lower left second premolar. Now we we are ready for the second auto transplant. The lower left wisdom tooth was transplanted to the lower right first molar. Here we can see the second auto transplant. At this time, I asked the patient to wear a symmetric interarch elastic for midline correction. The final job to do was implant installation. After osteointegration, provisional implant prosthesis was made. This was debonding. Although there were 3 premolars at the lower left, the occlusion looks not bad. This is how it looked like after permanent prosthesis were completed. And here is the treatment comparison. 10 years follow-up, the occlusion still looks good, profile was maintained, and periapical film looks pretty fine for both auto transplants. This case was published in AJODO in 2021. I think it's a good example of the beauty of interdisciplinary treatment. The next case I like to share, she got even more congenital missing of 6 premolars. Maybe we can consider to close 1 premolar space in each quadrant. But it seems there will be 2 dental implants on the upper arch were required for final restoration. But I saw the possibility of the wisdom teeth. So we start with the space closure for this case. After we close most of the spaces, we start to try auto transplant from wisdom teeth to the congenital missing premolar space. The crowns were reshaped a little bit, were reduced a little bit to fit into the premolar space. But the